I'm Dr. Howard Elkin. I've been practicing cardiology in Whittier, California since 1985. I went to school at Medical College of Virginia, which is where I'm from. I did my cardiology fellowship at Northwestern University. But what we see mostly in cardiology are patients with chronic chest pain, chronic angina, and coronary artery disease. And that's really the basis of what I see, the bulk of what I see in private practice. Patients that have had diseased hearts, they do really well with EECP. And of course, the coronary population, which is huge. I would like patients to know about their options. There's no need to rush off and have a procedure which could have potential harm. This is so much easier. So I really see a big role in the future with EECP, both for the coronary population and those with heart disease. It's non-interventional. There's no side effects. There's no pharmaceutical products involved. So the reason why I like it so much is because it's effective. So it increases circulation. It decreases stress in the heart muscle. It's a win-win situation, and it's all done without any pharmaceuticals or without any procedures. And in my way of thinking, it's a great way to treat patients with chronic coronary disease. And then once you have to suffer from uncontrolled angina or chest pain when they have this as a viable alternative. I still am amazed at the fact that so many doctors don't even know what this is. I go to my cardiology conference and they say, Dr. Elkin, what would you recommend with this patient? I say, EECP. They look at me like, what? There's a lot of money in pharmaceuticals. When you look at that versus EECP is like not as much, it's not as yielding financially. I hate to think that really plays a factor. I don't know why it's not more popular. So I believe we could cut down on hospitalizations in this country if we use this technique more often in patients with stiff hearts, patients that have been in heart failure. The number one cause for hospitalization in the population over age 70 is heart failure. When it comes to emergency intervention, acute MI, you want to have a stent. You want to go to the cath lab. Otherwise, you have options. They all don't have to have stents. In fact, in many cases, stents are probably not the best idea. There's a lot of elderly people that have had multiple stents, multiple bypasses, people that actually don't want any more interventions, people with patients that have difficult anatomy. So one size never fits all in this field. Then, of course, we have to consider their risks. And there's certainly there are risks in open heart surgery. There's risks in angioplasty and stenting. Of course, you hope to be at a good center where these can be minimized, but there are definite complications or potential problems with any interventional procedure. And again, that's another reason why I favor EECP, because it's non-interventional and there really is no side effect. Economically, it makes sense. And again, the risks are so low. I think the problem is that there's still a push in this country for intervention. There needs to be a movement in which cardiologists say, hey, we want more for our patients. I'm grateful for people like Sarah Gelati of Global Cardiac Care, who's really done a lot of work in getting the word out. I wish there were more people like her. We need a lot more than just one person. People start thinking of EECP as number one for chronic coronary care. I think it'd be a great thing because you'd have more centers. You'd have more doctors involved. You'd have more research. It's a win-win situation. And I think it would decrease the dollar spent on pharmaceuticals and expensive procedures. I just think the country would benefit. Patients would benefit. And that's the bottom line. The bottom line is always, what are we doing with the patients?